Hi, I'm Dr. Ted, and this is Fracture Friday. For this episode, I have an ankle fracture. It's actually what's called a trimalleolar ankle fracture. So that means that if you kind of look at your ankle, the bump on the outside of the ankle is broken, the bump on the inside of the ankle is broken, and then there's what they call the posterior malleolus, which is the back half, or the back third of the distal tibia that is also broken. So on this APX right here, you can see that the foot's no longer in line with the tibia. There's a fracture fragment on the medial aspect on the inside. The fibula, the distal end of the fibula is broken, is comminuted and displaced, and it's harder to see, but there's this fracture fragment in the back. So this is the lateral. Then again, that fracture fragment in the back is kind of hard to see, but we'll circle it here for you so you can see it. Okay, so what do we do for this? Okay, so what we do is open reduction internal fixation. So we make a skin incision and we put plates and screws in there. So we put a plate on the outside of the ankle, and it's a relatively long plate with a bunch of screws because this fracture is comminuted and there's a big space in the middle. Okay, and then we put 2 screws on the inside, the medial malleolus, in order to get the ankle mortise reduced. So like the ankle is like a mortise and pedestal, it fits together like this. So you have the fibula on the outside and the tibia is kind of shaped like that, I guess would be the way to do it. Okay, so we have to get that back together. Well, why do we have to get that back together? Well, we have to get it back together as anatomic as possible because the ankle is a very good joint. It doesn't seem to wear out like the knees and the hips do. We don't hear people getting total ankles as often as we do total knees and total hips and total shoulders. So the ankle is a good joint as long as it's not messed with. The minute you mess with it, the minute you separate it, the minute it's fractured, if you have 1 millimeter of displacement, your chance of post-traumatic arthritis goes through the roof. It's like 80%. So we don't want to let that happen. So we have to get the fractures back exactly the way they were so we can decrease your chances of having arthritis in your ankle later. So we don't want that. We want you to go back to having a normal life. We don't want it to be this a life-changing injury. We want this ankle fracture to be just something you talk about when you're drinking beer with your friends. So we put these plates in here. So this is the post-op AP, and we put the plate and the screws in there, and that reduced the ankle mortise the way it's supposed to. And then this is the lateral. Okay, now if you look at those two, you can see that there's no screws in that posterior malleolar fragment, right? Well, why? Well, because these are the rules. If the posterior malleolar fragment involves less than 25% of the joint surface, it doesn't need to get fixed. And this one does. It involves less than 25% of the joint surface for the distal tibia. And it reduces with what we call ligamentotaxis. So ligamentotaxis means that when I reduce the other 2 fractures, the ligaments that are attached to that fracture in the back pulled it back into its anatomic position, and it doesn't need to be fixed. It'll stay that way. So I hope you enjoyed this video. Thanks for watching. Hi, Dr. Ted. Thanks for sticking around after the video. If you'd like to see some more content from us, please subscribe to the channel and like this video.